to welcome the live audience, and I want to welcome everybody who's joining us today on Zoom for this special lecture. So I will be introducing Dr. Sears and today's lecture honoree, and then Dr. Zaiden, who is on Zoom, will be introducing Dr. Kantarjian. So the Blanche-Tullman lecture series was established in 2012 by Dr. Marvin Sears. Dr. Sears was a longtime chair and founder of ophthalmology and visual science at Yale, and the lecture was established in honor of his mother, Blanche Tullman, who passed away from acute myelogenous leukemia. This was actually the first lecture series dedicated solely to hematologic malignancies at Yale, and it is intended to bring to Yale pioneers that have made major contributions to our understanding of the current trends in hematologic malignancies, and in particular leukemia. So Dr. Zaiden, I welcome you to introduce Dr. Kantarjian.
Yeah, thank you so much, Stephanie. It's really a pleasure to introduce Dr. Kantarjian, who I could not think of anyone more suited to give this lecture about new developments on leukemia, because he has been a major force in many of the new developments over the last few decades, really, in leukemia, both in AML and ALL and CML as well. So Dr. Kantarjian is a professor and chair of the Department of Leukemia at the University of Texas and the Anderson Cancer Center. He's also the Samsung Distinguished Leukemia Chair in Cancer Medicine. His research has focused on translational and clinical development therapeutics in leukemia. Over the last 3 decades, he had made significant contributions that improved our understanding of both the prognosis as well as the survival of patients of CML, ALL, as well as discoveries of decitabine in myelodysplastic syndromes and clofarabine in the treatment of leukemias and many other medications. In fact, he and his group have contributed to more than 20 new drug developments in this space. He has been an author of more than 2,000 peer-reviewed publications, and he actually has been a major advocate of clinical research. He has mentored hundreds of leukemia doctors and researchers all over the US and the world, and has been a big advocate for introduction and use of therapies across the world, especially in low-resource countries. So it's really a pleasure to have Dr. Kantarjian, and we are very grateful to have you speak to us today about acute lymphoblastic leukemia. Thank you.
Thank you very much, Dr. Zaiden. It's really a great honor and a pleasure to give the talk at Yale, and particularly the special Tullman talk. What I'm going to do is review the progress and research in acute lymphocytic leukemia as it stands today. And a lot of the things I'm going to say may be very different from what you view ALL treatment today. So bear with me, I'll try to get you through the information and perhaps convince you that the times are changing very quickly. These are my conflicts of interest. So this is the standard of care in acute lymphocytic leukemia as it stands today. We give a lot of intensive chemotherapy with 15 chemotherapy drugs over 3 years. In childhood ALL, on the left side, the investigators have reported cure rates of up to 80%. On the right side is the data in adult ALL at MD Anderson. So up till 2010, we were able to claim a 5-year survival of maybe 50%. This is regardless of age. And it has improved since 2010. But I'm going to show you data that even the red curve is outdated in 2022. So it's important to just keep an open mind about the things which I'm going to mention, because I truly believe what I will show will be the next standard of care maybe 5 years from now. So one of the questions is, why is still there 30% difference or 40% difference in the cure rate between childhood and adult ALL with intensive chemotherapy? So this is because of 4 subsets which have different incidences and prognosis. So in childhood ALL, the hyperdiploid and ETV6 ranks 1 constitute half of childhood ALL, less than 10% of adult ALL. And these have a favorable prognosis with intensive chemotherapy. In contrast, historically, Philadelphia positive and Philadelphia-like ALL which constitute 50% of adult ALL and 15% of childhood ALL. These have had unfavorable outcomes with intensive chemotherapy. I'm going to show you that this does not apply anymore, neither for Philadelphia positive nor for the Philadelphia-like ALL. So if you use the intensive chemotherapy for 3 years, what is the cost of this traditional intensive chemotherapy? So you're using a lot of chemotherapy over 3 years. This could be manageable in the ivory towers, leukemia centers of excellence. But if you apply this to the community practice in emerging nations, among poorer and disadvantaged populations, there's a very high dropout rate due to the socioeconomic conditions as well as in the infrastructure and support. Even then, the frontline therapy will cost $500,000 in the United States, and if the patients relapse, that's $2 million. And moreover, there are multiple long-term complications, including organ dysfunctions, healthcare issues, psychological and social issues. So what is the solution to this? So let me try to show you some data from other nations. So this is Peru and India. And these are recent reports. And what they show is a cure rate in childhood ALL, not of 80 or 90%, but in the range of 60 to 70%. If you go to the older patients, so these are the patients that we treat more commonly, the cure rate is anywhere from 10 to 27%. And this is simply because the intensive chemotherapy for 3 years is not feasible among many of the patients. So the solution, in my view, is to try to develop different regimens which incorporate the newer treatments which have been discovered in the last 10 years. So for example, the third generation BCR-ABL kinase inhibitors like ponatinib in Philadelphia positive ALL, and also incorporating new antibodies that target CD19, CD20, and CD22, and perhaps consider that the best role of the CAR T cells is not in active salvage disease, but as a consolidation in remission in first, second transplant. Also, we need to measure the disease in better ways. So there's a way that's called next generation sequencing that measures the immunoglobulin heavy chain of the particular ALL. It can analyze up to 3 million cells, and this will allow us to decide on changing the therapy and the duration of therapy. So I'm going to show you at the end what we refer to today as the dose-dense mini-CVD Inoblina regimen with or without the CAR T cells. This is a 7-month regimen, which I'm hoping may become some form of a standard of care 5 years from now. This is not fiction. We did the studies now in ALL salvage with good results, and we have moved it to the older patients. So this is something that is happening. So this is a regimen that contains blinatumomab, rituximab, inotuzumab, the 3 existing effective antibodies, and we do a condensed approach with chemotherapy. So rather than sequencing the chemotherapy followed by blinatumomab, we're doing it as a condensed regimen. So this is something that can be still improved upon. I'll show you some of the results. So why do I believe that it is time to break with the 40-year-old tradition? I believe so because in Philadelphia positive ALL, I'll show you that non-chemotherapy regimens without the transplant are giving outstanding results. Also in the pre-BALL, less chemotherapy for shorter durations in combination with these antibodies are improving the outcomes significantly. I'm not sure about T-cell ALL because we do not have antibodies which are broadly available to treat T-cell ALL, but I'll show you some of the data with the incorporation of venetoclax and asparaginase nelarabine at the end. Now, anytime you break with tradition, it bothers some of the skeptics, the traditionalists. So I'm showing this slide just to show you how times change. So this is a slide from 1970. This was the time when Ara-C was discovered as a treatment for AML. And there was a debate then between a very eminent hematologist, Dr. Crosby, and Dr. Freirach. And the question was, even though we have RSE, should we treat or not treat acute myeloid leukemia? So the answer is obvious today. We treat almost all leukemias, but it was not obvious 50 years ago, and this was 15 years after I was born. So what seems unusual or out of the norm can become very quickly a standard of care within a lifetime. So at MD Anderson, we developed the hyper-CVAD regimen in 1992. We changed the CNS prophylaxis from radiation therapy to intrathecal. That became a standard of care. In 2000, we added the rituximab to Burkitt and pre-BALL. This was confirmed in randomized trials, which were published in 2017, and this has become a standard of care. In Philadelphia positive ALL, it was only in 2000 that we added imatinib to hyper-CVAD. We replaced it with dasatinib in 2006 and with ponatinib in 2010. And the hyper-CVAD dasatinib followed by transplant is what is currently the standard of care in the United States in 2022. And I'll show you that it's probably old-fashioned, outdated, and perhaps obsolete. The big breakthrough came, of course, with the discovery of the new antibodies that were highly effective, more effective than intensive chemotherapy, and which targeted two of the cluster designation. So blinatumomab, a bispecific T-cell engager that targets CD19, and inotuzumab, an antibody drug conjugate that targets CD22. So on the left side, I show again the data in the younger patients. So this is patients up to the age of 60. And since 2010, there is an improvement. So now the 5-year survival is over 60%. On the right side is the data with mini CVD inoblina, which started in 2010. And this is where we had a big improvement in the 5-year survival from 20% to about 50%. So we still use the hyper-CVAD at MD Anderson in contrast to many other places where pediatric-inspired regimens are used, because it's easier to incorporate it into the newer targeted therapies. And because at our institution, we found that hyper-CVAD, which is also a pediatric-inspired regimen, performed as well as the asparaginase-containing regimens during the induction. Now, for people who use the hyper-CVAD, I would like to draw your attention to a review in Cancer, which gives you some vignettes and pearls as to how to reduce the myelosuppression complications. The key issue is in the even courses, we reduced the methotrexate by 25%, and the RSE from 3 to 2 grams per meter square. But there are other small clues to improve the toxicities of this regimen. Now, when I'm going to show you the research at MD Anderson, you're going to be wondering why we're resorting to Bayesian designs with single-arm trials, and I'll try to explain my position. But also, why is it that different regimens have been developed differently? And this is essentially because a lot of the times it is what we propose and the drug companies offer us in terms of free drugs. So the evolution of a lot of the IND studies at MD Anderson were based on if and when the antibodies were available and free on IND studies, as well as on the maturing Bayesian-based data. So we started with the mini CVD in 2010. We added the blinatumomab later in 2015. In the younger patients, the hyper-CVAD started in 2018, and I'll show you that. And I mentioned the dose-dense mini CVD. This started only September 2021, and we opened the study for the older AML a year later. So I'm going to show you some of the evolution of these studies. So let's start with Philadelphia positive AML. In 2000, this diagnosis was a death sentence unless the patient had an allogeneic donor. So if the patients did not have a donor, even though 90% of them went in a complete remission with intensive chemotherapy. They almost all relapsed and died. If they had a donor, we gave them the transplant in remission, and the cure rate was about 30 to 40%. At MD Anderson, we added the imatinib to hyper-CVAD in 2000. Allogeneic transplant was almost always done in first complete remission. In 2006, we replaced that with dasatinib, and we started doing the transplant only if the patients were still PCR positive. In 2010, because 20% of the relapses were with the T315I clone, we replaced dasatinib with ponatinib. The patients were living longer. 10 to 15% were developing CNS leukemia with the 8 intrathecals. So we increased this to 12 intrathecals, and we did the transplant less and only if there was no major molecular response. In 2017, we switched. So this was the drastic change, eliminating chemotherapy and transplant and using 2 targeted therapies, ponatinib and blinatumomab. So I'm going to show you the sequence of the studies, but I'd like to draw your attention that none of these studies were a randomized trial. And I'm going to come back to this for the sake of the younger students and others, because we have been indoctrinated that the only way to advance research in medicine and in cancer is through randomized trials. And I'm going to probably state that that depends on where we are. So this is the progress in Philadelphia positive ALL. Before 2000, the patients died. Since 2000 to 2010, the cure rate or survival improved to 40%. Since 2010, it went to a 5-year survival of 70%. Now, the hyper-CVAD dasatinib was taken by the Southwest Oncology Group. It was tested in a single-arm trial, and they found that they could reproduce the data from the single institution, a CR rate of 88% and a 3-year survival of 70%. And they showed at that time that doing allogeneic transplant in first remission improved the outcome. So this became and is still the standard of care in the United States, hyper-CVAD dasatinib followed by allogeneic transplant in first complete remission. Now, people questioned whether dasatinib was superior to imatinib, and they waited for the randomized trials. So this randomized trial did not come from the United States. It came actually from China, where children with Philadelphia positive ALL were randomized to chemotherapy with dasatinib or imatinib, and that study showed clearly that the 4-year survival was superior with dasatinib, 88 versus 69%. But notice on either arm, the results are better than in adult ALL. So this is a common theme. Children with ALL do better than adults with ALL, whether they receive intensive chemotherapy, allogeneic transplant, CAR T cells, antibodies, or any other modality so far. Now, the hyper-CVAD ponatinib started in 2010 because ponatinib was toxic. We reduced the dose very quickly to 30 milligrams in CR, to 15 milligrams in complete molecular response. And we published the data on the 86 patients treated with this regimen, CR rate 100%, PCR negativity 84%, 5-year survival shown on the left side, 75%. And now we have a longer follow-up, so this is very solid data. But for the first time, on the right side of the slide, we showed that perhaps allogeneic transplantation is not necessary in all patients. So the blue curve is actually the patients who did undergo transplantation, either by physician or by patient's choice. So this was a quarter of the patients, and they did worse. The 12 intrathecals abrogated or eliminated the CNS leukemia. So now we're sticking with 12 intrathecals. And this is the best we could do to convince people who wish for the randomized trials. We did the propensity score analysis that showed that ponatinib was superior to dasatinib in our institutional studies. Now, in the meantime, blinatumomab and inotuzumab were undergoing the single and randomized trials. And the randomized trials showed that in the subset of patients with Philadelphia positive ALL refractory relapse, blinatumomab and inotuzumab were superior to intensive chemotherapy in terms of improving the CR rate and perhaps improving survival modestly. So because of this, we went to a regimen in 2017 that skipped the intensive chemotherapy and skipped the transplant. And we used ponatinib and blinatumomab during the induction, and then blinatumomab for 5 cycles. The ponatinib is, as of today, indefinitely, but based on the NGS MRD studies, we're thinking to follow a strategy similar to CML, where if the patients are NGS MRD negative for 5 years, maybe we'll stop the treatment, but we're not there yet. But let me show you the data, which is going to be published in Lancet Hematology in the next couple of months. So we treated 63 patients, 43 were newly diagnosed Philadelphia positive ALL. So if you look at those 43 patients, in the middle column, the CR rate is universal. Complete molecular response rate also in most of the patients. And for the first time, the estimated 2 to 3 year survival is 95%. So this is better than anything we've ever had. And only 1 of the 43 patients went to transplant. Now, for patients with a refractory relapse Philadelphia positive ALL or CML chronic phase that evolved into the lymphoid blastic phase, the outcome is still bad. So we still use the hyper-CVAD, ponatinib, blinatumomab in those 2 subsets. And this is to show you how quickly the patients achieve PCR negativity. So if you treat Philadelphia positive CLL, you are used to the fact that the PCR does not become negative till 3 to 6 months into a remission. Here I show, and we did this, the PCR weekly, simply to see whether we're going to see some major signal. And we were surprised to notice that within the 4 weeks of induction therapy, 2/3 of the patients became PCR negative. And before the next course, 3/4 of the patients had become PCR negative. So very quick achievement of PCR negativity and NGS MRD negativity. And now I show the survival in the red with the ponatinib blinatumomab compared to the hyper-CVAD ponatinib. So the question is, will you do a randomized study today comparing ponatinib blinatumomab to hyper-CVAD imatinib? So this is an important question, and I have to tell you that this is a randomized study that's ongoing in Europe. So you have to decide, is this a randomized trial which provides equipoise, which is the basis of a randomized trial, meaning that the investigator does not know whether one or the other arms of the randomization is superior. So as I mentioned, we still use intensive chemotherapy with ponatinib blinatumomab in CML chronic phase that evolves into a blastic phase, in refractory relapse Philadelphia positive ALL, and then in 2 other rare subsets. So patients with Philadelphia positive ALL, but where the FISH is positive on the mature granulocytes. These are patients mostly with P210 Philadelphia positive ALL. And another rare subset, which we did not think existed, but we had now 7 cases of Philadelphia positive ALL and CRLF2. These do badly and they need the intensive chemotherapy. Now, next, I'm going to move to Philadelphia-like ALL. So for the students and the fellows, Philadelphia-like ALL is an ALL entity where the cytogenetics do not show the translocation 922, and the molecular studies do not show the BCR-able translocation molecular events. But they have a genomic profile which is identical to Philadelphia positive ALL and different from the other subsets of ALL. So what we've learned is Philadelphia-like ALL has a bad prognosis with intensive chemotherapy. On the left side is the data from St. Jude's. On the right side is the data from MD Anderson. And what you notice is historically with intensive chemotherapy, the cure rate in children was 25%, the cure rate in adult also was a low 20%. We now know that this is more common in Hispanics because they have a GATA3 variant that increases CRLF2. So they have a lot of Philadelphia-like ALL. So Philadelphia-like ALL is divided into two entities. So this is just a quarter of pre-B-ALL, but 50% of Hispanics pre-B-ALL. Most of them, 80%, have CRLF2 overexpression, and half of these have a JAK mutation. So if you take 100 patients with ALL, 25 will have Philadelphia-like disease, 20 will be CRLF2 overexpressed, and 10 of them will be JAK2 mutated, and these are bad. These patients may still need the allogeneic transplantation, but otherwise, the other Philadelphia-like, I'll show you, do well with the addition of the antibodies. Then there's an uncommon subset, so 5 of the 100, or 20% of the Philadelphia-like, that have ABL translocations. So this is not the BCR ABL, but they are ABL translocations to other genes, and these patients respond to BCR ABL kinase inhibitors. So here I show it more schematically. In blue are the translocations of ABL1 to other genes that produce an ABL translocation that responds to the BCR ABL kinase inhibitors. Also, the same applies to PDGFR beta translocations. So these patients with ABL or PDGFR fusions, we treat them on the Philadelphia positive protocols. There is another subset with not JAK2 mutations, but with JAK2 translocations, and it is possible that these may respond to ruxolitinib. We do not know, and they are rare, so we haven't been able to treat them on our studies. This is a study from France, where 24 patients with essentially ABL translocations were treated with BCR ABL kinase inhibitors and intensive chemotherapy. And they showed in this study that, like Philadelphia positive ALL, these patients who receive chemotherapy and a BCR ABL kinase inhibitor have a high response rate, close to 90%, and a 4-year survival of 60%. So these ABL translocated ALL, we treat the same way as Philadelphia positive ALL. So to summarize, Philadelphia-like ALL has the same genomic profile as Philadelphia positive ALL, but not the 9E22 translocation and not the BCR ABL molecular events. It constitutes 25% of the adults. Historically, it has a poor prognosis, but not anymore. It is more common among Hispanics, and it is two distinct entities, the CRLF2 overexpressed and the ABL translocated, which we treat like Philadelphia positive ALL. So the newer approaches are actually improving the outcome in both of these entities, and I'll show you that for the particular subset of CRLF2 overexpression. Next, I'm going to talk about the therapeutic revolution in ALL, and I show it on the slide. It comes from two subsets. The first one are the newer antibodies, including antibody-drug conjugates and bispecific T-cell engagers that are targeting CD19, CD20, and CD22 and CD20. So you may be aware of the CD20 BiTEs, which have shown very high efficacy in lymphoma. So we'd like to use them to replace rituximab, and that way we have 3 antibodies which are highly effective. On the right side are the CAR T cells, which are a revolution in both lymphoma and myeloma, but I think for them to be important in ALL, they have to be used in the setting of minimal residual disease. So in 2009 at MD Anderson, we were aware of the inotuzumab studies in lymphoma, and so we convinced the company to give us an investigator IND study, which we did initially with a single dose per course and then in fractionated doses. And that study matured into 90 patients that showed that a single antibody produced a marrow CR rate of 58%. In the meantime, the randomized trials in lymphoma with inotuzumab failed. So the company went ahead with the randomized trial. And I show here the data in the randomized trials. So there were two studies, two parallel trials with blinatumomab and inotuzumab. These were both randomized trials that compared the antibodies to intensive chemotherapy. And both trials showed that blinatumomab and inotuzumab were superior to intensive chemotherapy in refractory relapse ALL. I want you all to also notice that even though we reported a marrow CR rate in the MD Anderson studies of 59%, because of a better selection in the randomized trials, actually the randomized trial showed a higher marrow CR rate than our institutional studies. So both these agents became FDA approved in 2014 and in 2017 as single agents for the treatment of refractory relapse ALL. But what you see is the benefit is very modest. So very quickly, we decided this is not how we're going to use them. And we incorporated them rapidly into the standard chemotherapy. So I'm going to show you next the data with hyper-CVAD blinatumomab in pre-BALL. So the design of the original study was 4 cycles of intensive chemotherapy. And because the prevailing notion was you cannot dose dense blinatumomab with the chemotherapy because the chemotherapy kills the T cells, so theoretically blinatumomab would be less effective, the company allowed us only to use it in sequence. And then we shortened the duration of the maintenance from 2 years to 1 year. And later on, the other company allowed us to add inotuzumab. So we had 2 of the antibodies as free drugs that we incorporated into the hyper-CVAD blinatumomab inotuzumab. So we are going to publish the data in the first 63 patients, again in Lancet Hematology in the next couple of months. The CR rate was 100%, MRD negativity 95%. And for the first time in pre-BALL, in adult pre-BALL, the 3-year survival was 85%. On the right side, I show the data since we added the inotuzumab. So by adding inotuzumab to the hyper-CVAD blinatumomab, we improved the outcome, perhaps because we so far have not seen any relapses. So that's why I think that this is perhaps a potential standard of care in the future. Now, let's look at the data compared to the previous hyper-CVAD ofatumumab, a 20% difference in the survival at 3 years. And this shows the subset in blue of patients with Philadelphia-like disease, where the survival is not anymore 20% as I showed you, but it has gone up to 70%. And this shows the survival with or without the transplant, again suggesting that the role of transplant is not that important and not for all patients with ALL. So I showed you the top 2 slides, the top 2 studies from MD Anderson. And what you see is this is a common trend now. So even though randomized trials has been or is the standard of care in cancer research, what you see is many of the studies from Germany, France, and other places, they are using single-arm trials in order to optimize the regimens before taking them to a final randomized trial. And they are showing similar data with high CR rates and high survival rates. Now, I mentioned randomized trial and Bayesian designs for several times, and I want to explain myself. Perhaps not to the senior physicians who may be skeptical about this, but perhaps for the fellows and students who have been educated to appreciate randomized trials as the only way to advance research in medicine and in cancer. So we started the studies with inotuzumab in 2010, with blinatumomab in 2012. These drugs were FDA approved in 2014 and 17. In 2022, a decade later, we still use blinatumomab and inotuzumab as single agents in ALL salvage. We have not yet established the combinations as a standard of care. Now, let's go back to the history of randomized trials. What people may not know is the randomized trial started only in 1955. The first randomized trial in cancer was done by Dr. Freirach. This was a time when he was at the NIH, and he showed a correlation between low platelets and bleeding. So people asked him to do a randomized trial where he gave fresh blood, and he showed that the bleeding decreased. In those days, we did not have pheresis machines. So he was asked to do a randomized trial of fresh blood versus stored blood to show that fresh blood would reduce the bleeding in children with ALL. And he showed that, and when the trial turned to be positive, they accused him of falsifying the data. So this shows you a trend that perhaps randomized trials are established today, but maybe we can question them. So let me tell you why we should question them. So today in Europe, there is a phase 3 study of ponatinib, blinatumomab versus intensive chemotherapy, imatinib. I do not believe there's real equipoise. So the basis of all randomized trials is that they assume there's a knowledge equipoise. So you're sitting in the room with the patient and you say, I'm going to randomize you to this protocol. And I truly and honestly do not believe that the new treatment is better than the old one. Now, randomized trials are okay if you are in a research desert. So if you were in 1965 or 1970 or 1980, where there was very little to offer to the patients, you could do a randomized trial with a new drug X. Or if you have a highly curable disease like ALL. Today, we are in the land of research plenty. There are multiple targeted therapies in ALL. And if you do a randomized trial that randomizes the patients to the standard of care versus drug X, that the results of that randomized trial will be outdated by the time the data matures. And if you think about it, our whole life experience is actually not randomized, it's Bayesian, the way we raise our children, the schools we choose for them, the restaurants we choose, the careers, the partners. You do not go out 50 times with a new person and 50 times with another new person, and then look at your experience and decide which one you're going to marry. You actually switch from person A to B and C very quickly and gain a cumulative experience that allows you to decide on what to do. Now, in the editorials, you may have read those two examples, which are obvious examples. So parachutes were not based on randomized trials. We did not throw 50 people without a parachute and 50 people with a parachute from airplanes to decide that parachutes save lives, and the same applied to seat belts and so on. Now, for the young people, they search Google all the time for the truth. So there are Google algorithms that we use in our daily practice to decide what's good and what's not good. So I'm going to propose that perhaps what we have to do in cancer research and in medical research is develop apps that incorporate the research in cancer, for example, and then we ask the app, based on the preclinical data and the clinical trials so far, what would be the best design to investigate a new drug in the cancer research. So think about it and see if it's something that could maybe challenge the concept of randomized trials. And this is not new knowledge. So what you notice is the FDA today is approving several drugs, not based on randomized trials, but based on the results of even phase 1 studies. And we were taught historically that phase 1 studies are purely to identify toxicities and the phase 2 dose. Now we know that there are several drugs like crizotinib in non-small cell lung cancer and vemurafenib in melanoma that were approved based on the results of phase 1-2 trials. So I'm going to propose, at least for ALL, which is a land of research plenty, that we hold the randomized trials because they will slow the progress and the discoveries, and replace them with Bayesian trials. Actually, randomized trials which are poorly designed can give you false leads. So there was, in fact, an ALL study using a pediatric-inspired regimen. It was a cooperative trial in the United States that randomized patients to using a regimen with asparaginase and a randomization to inotuzumab. I objected vehemently to that study because I said that asparaginase and inotuzumab will cause veno-occlusive disease and mortality. This was not believed, and the study was stopped 2 months ago after 400 patients were entered because, as expected, there was a higher mortality in the investigational arm because of the anticipated synergistic toxicity of asparaginase and inotuzumab. So I think, at least in ALL, we have to revert to single-arm trials until we optimize the regimen that could be compared to the standard of care. Now, next, I'm going to discuss minimal residual disease. I'm going to draw your attention to figure D. This is patients with adult ALL who are in remission and who are MRD positive. So what you see is their cure rate is at best 10% compared to over 50% for the patients who become MRD negative by any methodology, but this was mostly by flow cytometry. So this is where we started using blinatumomab for 5 courses in the setting of MRD positive ALL in first or second remission. We observed that 80% of the patients became MRD negative, and the 4-year survival was not 10%. It went up to 60%. And on the right side, I showed that the effect of transplant was minimal. So perhaps this is where we can do the CAR T cells instead of transplant, because if you avoid the transplant-related mortality, maybe the cure rate will be even higher. So this is why it's important to measure MRD, not by flow cytometry looking at 10,000 cells, but by the next generation sequencing for the immunoglobulin heavy chain that looks at 1 million to 3 million cells. So this is a study in the older ALL. So I'm going to show you an update just for information purposes. So this is the study that we did and we took from the ALL salvage, where we did minimal chemotherapy with inotuzumab and added the blinatumomab later on. And we showed that by matched analysis that the new study was superior to the old study of hyper-CVAD. The question is, can we do a randomized trial, and what would be the control arm now that there's a significant difference in the outcome compared to historical data? And this is the same happening elsewhere. So in the United States, there was a single-arm SWOG trial of chemotherapy with blinatumomab, and similar studies were conducted again in Germany and Australia and by the French group. All of them are single-arm trials combining chemotherapy with one of the 2 antibodies, producing high CR rates and good early outcomes. Now, in T-cell ALL, as I mentioned, we do not have an antibody. But what we have is something that might work. So intensive chemotherapy with a lot of methotrexate, Ara-C, and asparaginase. And recently, we have seen that nelarabine works there, and venetoclax might work. So we have started combining these drugs in a trial and error formulation. The other thing that is important is the fact that T-cell ALL, there's a subset of T-cell ALL shown here that has a genomic profile more like AML. I think this is the precursor T-cell ALL, where we need to start considering treatments that incorporate AML therapies. So this is the subset of T-cell ALL with a methylation profile identical to acute myeloid leukemia. And perhaps these are the patients that should be treated like AML. So this is the multiple reiterations of the hyper-CVAD asparaginase nelarabine regimen. Not yet ready for prime time, but in the past 2 studies where we added venetoclax and nelarabine asparaginase, we're getting survivals not of 60%, but over 70%. And we hope that this will continue with the updates. Now, one of the questions is, then when do we use allogeneic transplantation in remission? So we still use it in the patients with translocation 11q23 in precursor T-cell ALL, in patients with complex karyotypes, so abnormalities more than 5, and in the Philadelphia-like ALL with CRLF2 with JAK2 mutations. Otherwise, so this constitutes about maybe 15 to 20% of adult ALL, where we still use allogeneic transplant today and where we may use CAR T cells in the future. So this is an update in the ALL salvage. So this is where it all started. So even though I'm showing it at the end because it's ALL salvage, this is where all the research started with the MCVD inotuzumab blinatumomab. And I showed the update in the 112 patients treated so far. Marrow CR rate 83%, MRD negativity 83%. The veno-occlusive disease after we fractionated the inotuzumab and capped the dose has gone from 9% to 1%. ALL relapse used to be again a death sentence. In the overall 112 patients, the 5-year survival is 30%. Since we added the blinatumomab, we have shown, like in the younger patients, when we added ino-to-blina, we showed an improvement in the survival. In the salvage, when we added blinatumomab to the mini-CVD ino, we have shown an improvement in the 3-year survival to 50%. In salvage 1, the potential 5-year survival is now 40%. And we do not see a difference with or without allotransplant because I think we're losing a lot of patients to the transplant complications. So if we do the CAR T cells, maybe we'll improve the survival further than 40%. Now, people may say, well, we have the CAR T cells, why have you ignored them? So on the left side, I show the data with inotuzumab. We're not curing too many patients, maybe 20%, and we need the transplant here. In the middle are the newer CAR T cells, the approved CAR T cells for the older patients. And what you see is the 2-year survival is probably 20%. And now I show you in blue, the post-amendment, where the 3-year survival is 50%. So I think in ALL salvage, if I have a patient who has relapsed, I would use the mini-CVD inoblina, and then I would do the CAR T cell to improve the potential cure rate. Now, why have I insisted several times on the CAR T cells to be tested in minimal residual disease? I think the CAR T cells today are being used the same way we used allogeneic transplant in the 1970s, in active disease, and we're curing 20 to 30%. If we start using the CAR T cells in minimal residual disease, the same way as allogeneic transplant is used today, then perhaps we will cure many more of them. Now, people will object to this, saying, well, no, you need active disease to expand the CAR T cells. But the real-world data shows that, in fact, when you do the CAR T cells in minimal residual disease, which are the red and the blue curve, you potentially cure more patients than if you do it in the setting of minimal residual disease. So in summary, I think in Philadelphia positive ALL, ponatinib blinatumomab will be the future form of therapy. And I think the future of pre-B-ALL will be with much less chemotherapy for shorter duration, combined with the antibodies, using the CAR T cells in the setting of minimal residual disease, and monitoring patients by next generation MRD. Now, can we do better than this? So this is what I showed you with what I called the BRIC or the dose-dense mini-CVD regimen. And this is what we are testing today in older ALL, and we may move it to younger ALL. So this is very similar to what you do in lymphoma, just 6 courses of therapy, and perhaps the need of CAR T cell consolidation. But can we do better than this? So you may be aware that there are T cell engagers which target more than CD19 or CD20. This is what we call the tetra-specific T cell engagers. This is not science fiction. These will be developed, and there are also CAR T cells which target more than one target, so dual CD19 and 20 CAR T cells. So it is possible that in the future, we will use very little chemotherapy to induce the patients in remission. We'll consolidate them with the tetra-specific T cell engagers, and then we'll further consolidate them with CAR T cells. So a total duration of therapy of 3 to 4 months, which will not be toxic and which will be highly effective and potentially highly curable. Thank you for your attention, and I'm happy to answer any questions.
Thank you for this absolutely fantastic lecture. And we actually have hematology faculty and trainees in the room. So I encourage everybody to ask questions in person. You're welcome to come up to the podium, or I'm happy to repeat your questions from the audience. And then, Amr, are you seeing questions from in Zoom?
So I don't see questions in either.
All right, we have the first in-person question.
Okay.
Dr. K, thank you for that excellent presentation. You know, I think the pH positive word is largely driven by what happens at MD Anderson. And it's interesting to see pH negative disease in ALL is going that direction as well. Thank you for those excellent slides.
Thank you.
You show a couple of interesting but equally provocative slides, right? Innovate and Blina trials, when published, we historically compared them against standard of chemo, while the CAR T cell trials had ENA and Blina failure. In my mind, those were probably more refractory diseases. Based on the CR and the MRD rate that are reported across CAR Ts, as is approved with FDA agents, what's the hesitation of you trying them first? And why are we still pursuing with ENA or Blina approaches with chemotherapy? I think the answer to that will lead to my next question.
So that's a very important question. And the answer to this is I do not compare the single agent antibodies to the CAR T cell results. What you have to do is compare the hyper-CVAD, Blina, and salvage to the CAR T cells. So with the CAR T cells, if you take 100 patients, you're infusing probably only 2/3 of them because you lose some of the patients in the process. With the mini CVD Blina, you are treating 100% of the patients, and you're getting a marrow CR rate of 85%. And that does not negate the need and potential use of either allogeneic transplant or CAR T cell as a consolidation. So I do not see the antibodies and CAR T cells as either or competitive modalities. I see them as, in fact, synergistic modalities that have to be used in the proper sequence.
I think that begs the question, since we're competing for the CD19 targets with Blina and CAR T, why not just stick to your mini hyper-CVAD plus inotuzumab and then a different target, right? Because it's 19 versus 22 expressions. Begs the bigger question of how to sequence this. Should Blina be avoided, especially in likely CAR-needing patients, or however you design it, because there are some issues of competing for the same antigenic targets?
So that's an important question, and the CAR T cell experts have always brought the issue. If you treat the patients with blinatumomab, you may lose the target, and there were data that showed that the outcome may be worse. But there is this real-world data which I've shown you have updated the results, and they've shown that the results were worse with blinatumomab only in the patients who failed blinatumomab. In the patients who respond to blinatumomab, when they relapse and they get the CAR T cells, the results are still as good. So it was a selection of the patients who were refractory to blinatumomab who were also refractory to the CAR T cells. So I have no hesitation and no issues with using blinatumomab before the CAR T cells, because loss of the target is minimal, if at all. And also because the updated data do not show that exposure to blinatumomab worsens the outcome of the CAR T cells. It was an epiphenomenon of the patients who were refractory, truly refractory to blina, that also were refractory to the CAR T cells.
Okay, thank you. And last comment I was going to make was, now I'll let others take the question because a couple of my other colleagues have. Go for it, Nikolai.
And so Nikolai gets you. I have just one question. Have you noticed that, by maybe not running phase 3 trial, randomized trials, but these earlier phase trials, that you have better inclusion of people who may be more hesitant to enroll in trials, so underrepresented population?
Well, that's one issue because, as I mentioned today, with all the targeted therapies, with the multitudes of targeted therapies, it's very difficult for an investigator to truly and transparently state a situation of equipoise, meaning that you tell the patient, look, I have hyper-CVAD imatinib versus ponatinib blinatumomab, and I truly believe that I do not know the answer to that strategy. So I think if you tell the patient, look, we have gathered all our knowledge, and to the best of my own knowledge, this is a trial that will help you. First, it will reduce the restrictive eligibility criteria, because you can negotiate better within your own IND studies and in single-arm trials to reduce the obstacles. And second, you probably can convince the patients better that what you're offering them is truly what you believe is best for them.
Thank you so much. Dr. Bodaltsev, come on to the podium.
Dr. Kantarjian, thank you very much for excellent presentation. My question is about use of ponatinib and blinatumomab in Ph-positive ALL. So, this is applicable to younger and older patients, and obviously there is a lot of concern about ponatinib-related toxicity. Would you see any contraindications, and what do you think about long-term use of ponatinib after you finished initial treatment? How long should we continue?
So you're absolutely correct that ponatinib has significant toxicities. That's why we reduce it from 45. Actually, in the ponatinib blina, we start with 30 milligrams, and we reduce it to 15 milligrams, usually within a month, as I showed you. But your question is very legitimate. What do we do with all the patients who have already existing arterio-occlusive events or cardiovascular events? So in those situations, there's one could design a trial with bosutinib blinatumomab or with dasatinib blinatumomab. But you're going to encounter perhaps a relapse rate of maybe 10 to 20% with T315I clones. You hope that the blinatumomab will suppress these clones. And if you try to design a regimen like this, I would encourage to use the blinatumomab starting day one with the induction, rather than as the Italians did, where they used it 3 months into a remission. So today, if I have a patient with cardiovascular contraindications, arterio-occlusive events, then by all means, I could start them with dasatinib blinatumomab, but then you have to somehow carve out a time space where you give them ponatinib to try to eliminate those perhaps 10% of the patients who can relapse with the T315I clone. Alternatively, you can see what the residual disease is left with next generation sequencing. And if you see it there, then you can change to ponatinib then.
So following with next gen sequencing rather than with PCR is what you suggest, because PCR is reasonably sensitive as well.
So the PCR detects 100,000 cells. The NGS, when successful, can measure 3 million cells. We're doing both of them. Another interesting finding, which I didn't mention, is we have patients who are NGS negative and PCR positive at low levels. So you could say, well, is this a fluke? How can that be? And we think that the NGS, because it measures the immunoglobulin heavy chain, is looking only at the lymphoblasts, but there could be some BCR-able signals in the myeloid cells, which will not cause an ALL relapse. And in fact, this is what we are noticing. There's a subset of patients who are NGS MRD negative, PCR positive at low level, 0.01 or 0.1%. And these patients are not relapsing. So we're not sending them to transplant if they are NGS MRD negative. But we haven't published on this. It's a twist to some patients, so more specialized than what one needs to know.
And duration of ponatinib in younger patients who receive treatment with blinatumomab ponatinib combination.
So we do not know, but here's what we're going to do. We're going to adopt a strategy similar to CML. We're going to say if the patient is NGS negative, MRD negative for 5 years, we're going to either stop the treatment for toxicities or accidentally if the patient doesn't want it, or perhaps in the future on purpose. We're going to tell them, you have been NGS MRD negative for 5 years. We think the disease is not going to relapse, and perhaps ponatinib will buy you more problems than benefits. So we're going to stop and see what happens. The same way as we do in chronic myeloid leukemia with the concept of treatment-free remission, but we're not there yet. We need to get to a population of patients who are NGS MRD negative for 5 years or at least 3 years to offer them that kind of a treatment option if they have toxicities or side effects.
Thank you.
Right, I think we're at the top of the hour. Dr. Kantarjian, thank you so much for this absolutely spectacular lecture. And Dr. Sears, thank you for bringing these amazing advances to our lecture hall today. So thank you so much. And thank you, Amar, for the wonderful introduction.
Thank you very much for the honor of inviting me to this special lecture.
A pleasure.